طيب، بسم الله الرحمن الرحيم، والصلاة والسلام على أشرف المرسلين. الليلة عندنا ضيف يعني عزيز جدا في محاضرة قيمة جدا عن Assessment of Autism Spectrum Disorder in Adults. ضيفنا الليلة أو مقدم المحاضرة الليلة دكتور عماد الدين حسن إسماعيل البيلي. He's currently working as a locum psychiatrist, consultant psychiatrist in learning disability with the Barnsley Community Learning Disability Team in Southwest Yorkshire, UK. Dr. Imad started his psychiatric training in Sudan in 1996, and then he traveled to UK in 1998. He has worked mostly in the field of intellectual disability and neurodevelopmental disorder, including autism spectrum disorder, including working with autism team in the Bedfordshire, and he's currently looking, inshallah, in the future, once the situation stabilizes in Sudan, to try to kind of move his experience to work in Sudan, inshallah. دكتور عماد اتفضل.
شكرا جزيلا دكتور ياسر، وشكرا للحضور. السلام عليكم ورحمة الله. أتمنى أتوفق في إني ألقي بعض الضوء على الموضوع الشائك اللي هو موضوع كبير جدا. Assessment of Autism Spectrum Disorder in Adults is a very it's a huge topic that needs to be approached carefully and needs to be approached in steps, because the assessment includes the initial assessment includes diagnosis, and then the assessment of needs, and then how to approach those needs. But what I'm presenting today is only a very small part of this assessment. And I'm hoping from presenting this, especially for our trainees, that they are able to have some awareness of the clinical implications of assessment of autism spectrum disorder, and they also have some clinical knowledge and skills in identification and diagnosis of autism. Because when I arrived in the UK, I must confess that my knowledge, experience in the field of autism was very limited. And after some time, I especially after working in the field of intellectual disability, I realized that I needed to do more work and to explore this condition in more detail. So I would like our trainees to read more, and also to have this awareness of autistic spectrum disorder. I would rather use this term because this is the term which is used now in the ICD-11. So the rationale of presenting this topic is for the trainees to have some knowledge in identification and diagnosis. You may ask a question now. Usually, autism presents itself in early childhood. And I think I recall that you had lectures in assessment of autism in children presented by Dr. Aisha and also by Dr. Amani, if I can trust my memory. So the question that will always be asked, I mean, how do you expect to assess autism in adults, while it is a condition that is usually diagnosed during childhood? From my experience, I have assessed patients by the age of 50s and 60s, and very recently I've come across a patient who's over 70, who's presenting with very strong autistic traits. And usually when this happens, people just consider this person as strange, as different. And when I spoke to the carers of that patient, they just told me, this is just life. So this statement of this is just life is a statement that stops people from suspecting autism in adults, and just they take that for granted. Once you assess autism, then you assess the needs as well, and then you help the patient to access support and services. And also improve the mental health outcomes, because patients with autistic spectrum disorder, they do present in a different way with various mental health problems, such as depression, for example, because in depression, the communication, the facial expression is different from people who do not suffer from autism. And also that when you assess adults with autism, that increases self-awareness of their conditions, because most of the time is very distressing that when they think, why am I different from other people? Why do I present in this way? Why do people look at me as a weird, awkward person? So the self-awareness helps them to feel less distressed, and it helps them to develop coping strategies. And also, it helps to reduce the stigma. Talking about stigma, from my experience, this can go either way, because in some cases, people or individuals with autistic spectrum disorder are very keen to engage in the assessment. In very rare cases, individuals and their families, they were not keen to engage. In one case, I remember the wife of the patient was very unhappy that he was referred for assessment, and she didn't see any point of a setting for that. So I suspected that that was because of the stigma. So we need to be aware also that the stigma can go either way, and we need to work on that. So we try to define autistic spectrum disorder. That it's been defined as a lifelong neurodevelopmental condition. And before I go into the details of that, I need to talk about a little bit about what's happening with neuro developmental development. This neurodevelopmental definition, if you access the material of autistic spectrum disorder in like YouTube, in the media, you find people talking a lot about neurotypical and neurodivergent. And we need to be also aware of these terms. What do they mean? They refer to people who are not suffering from autism as neurotypical. And I try to avoid using the people with normal development and people with abnormal development. So the people with who are neurotypical, we can refer to them as mainstream in their neurodevelopmental. People with autistic spectrum disorder have some abnormalities in their neurological development. And these abnormalities are differences in the brain structure and brain development, but they are considered as natural variations rather than being deficits in the brain development. And these structural differences are important because they impact on the presentation, and they are relevant to the way they present. I think that I don't want to go into more details of this. It's just we need to know these differences, because they are very relevant to the presentation and to the symptoms. There are mainly structural differences in the volume of the brain, for example, in the cortical and prefrontal cortex area, which are related to decision-making, social behavior, and also some changes in the cerebellum related to the balance. The area of emotions, amygdala and hippocampus, and this is also very relevant in relation to emotional regulation. And for example, when patients with autistic spectrum disorder present with meltdown. They have problems with emotional regulations. And there are some changes in the neurotransmitters. So this is the main difference between the brains of or the neurodevelopment of people who are in the mainstream or neurotypical and people who are having some abnormalities, neurodivergent. I hope this explains the term. Now, this condition is present with persistent social and communication difficulties, rigid and repetitive thoughts, behaviors, and interest, and resistant to change. Iman Omar is asking about, shall we answer the questions now or shall we wait to the end?
It's up to you. If you like to answer now, it's interactive as you like. Yeah.
It's just a question appeared and now disappeared, I think.
Yes, you can answer, you decide, you have no problem.
Okay, I think if you talk about autistic spectrum disorder in general, these structural changes are peculiar for autistic spectrum disorder. ADHD is a different condition with different brain structures, and I think that we have still a long presentation to go through, so it might be not possible to go through these differences now. So these three characteristic presentation, plus or minus difficulties with sensory processing, difficulties with cognitive and behavioral flexibility, and difficulties with emotional regulation. So it's important also to know the ICD-11 criteria because the diagnosis is actually based on this criteria. And the criteria provide a framework for diagnosis, and the framework is based on observation and also developmental characteristic. The core features of autistic spectrum disorder: persistent deficits in social communication and interactions, including difficulties in understanding and engaging in reciprocal social interactions, difficulties in nonverbal communication, such as eye contact and facial expressions, challenges in developing, maintaining, or understanding relationships, restricted repetitive patterns of behavior, interest, or activities that include repetitive motor movements, repetitive speech, tendency to sameness. And by this, we mean people, they tend to do the same thing. They tend to dress this in the same clothes. They have like set of clothes that they dress every day. Sometimes they tend to eat the same food. And so they have this tendency to have the same habits, the same thing that they go through. They have fixed interest, and later I will talk about this fixed interest also, and one of the experiences I had with this fixed interest. An important criteria is that the onset of symptoms must be present from early developmental stages. Hence, we talked about why we need to assess in adults, although it starts in early ages, but sometimes it is missed. And the impact on functioning, it must cause significant impairment in social, educational, or occupational functioning. You might see people with autistic spectrum disorder, but they are managing to some extent, but still they are diagnosed with autistic spectrum disorder. So when we go through the assessment, before we start the assessment process, we do some screening, and we do this first consultation, and there is some tools that helps us to do this screening. The AQ is one of the tools that is used in primary care, and this help to identify individuals who are suitable for the assessment itself, and it is used also to help us to have the initial assessment. Once we have done the assessment, from my experience with the assessment, we start with clinical assessment. And usually we use the Royal College of Psychiatrists Diagnostic Interview Guide for the assessment for adults with autism spectrum disorder. You can find this guide if you Google and if you go into the Royal College website. Now, following that clinical assessment, then we apply some assessment tools. Two of them, they are used commonly. The EDOS tool, which is a structured assessment tool, which take like about 1.5 to 2 hours. And it is a quite comprehensive assessment. It has to be done face to face, and it aids into the diagnosis. And usually you combine the findings from the tool and the clinical assessment to get into to confirm the diagnosis. The tools that I mentioned here, they're quite comprehensive tools, structured. And if we need to talk about them, we may need a separate lecture to explain them. If you want to do the training for this tool, that it takes 2 days training, and sometimes it can be an expensive training to pay for, but it is a good training to do if you are interested in this field. It's usually applied by people from various professionals. It's not only doctors, like nurses, psychologists, occupational therapists, speech and language therapists. And this is usually the approach of assessment and getting into the diagnosis. It is done in a holistic approach, including MDT members, as I mentioned, the psychologist, speech and language therapist, and all these professionals. They must be included in the assessment and the diagnosis. So after all these talks, I'm just getting into introduction now. So the expectation, when we start the clinical assessment, you start by asking the individual or the patient, what are their expectations from this assessment? What are the main concerns? And you ask this question to the patient, but also to the family member who would provide collateral information. And it is very important to have this member of the family with a patient, because they can give very objective collateral information. Before you go into the details of the clinical assessment, you need to get the developmental history, and that's very crucial. When I work with autism team, we used to get that before the assessment and add that to the report. And also we look into some comorbid disorders. You need to be careful, because some people may be aware of this clinical assessment and they may recite the answers, and then when they give you the favorable answers, which can impact on the how reliable the assessment is. You also, from getting the collateral information, you will be able to identify the impact of these symptoms on others. So When you do the clinical assessment, you start by asking questions about social interaction, and the social interactions include like uh, the verbal communication, how the individual behave in social gathering, how do they um, present in um, informal gathering, informal meetings, or even in parties. Uh, so in these conditions, you look at the social communication first, and this includes nonverbal communication. They have significant difficulties in nonverbal communication that includes atypical eye contact. Even when they try to do eye contact, they will come across as staring, and sometimes they avoid eye contact altogether. They have problems in reading facial expressions, and this will come also when we talk about empathy. And also recognizing vocal tones. This can go in a way that if you're talking to them in a very loud voice, even if you are not confronting them, if you are not aggressive, they might perceive that in a different way. They have significant difficulties in understanding others' behavior, motives or intentions, others' expectations, reading between the lines. If you try to give some hints, or if you try to be sarcastic, that's one of the areas that autistic people find it very difficult. And they prefer straightforward uh, terms rather than having all these different terminology. And they can come across as blunt, abrupt, and rude, but this is the way they communicate. One of the patients I remember when they actually look into the terms in a very concrete manner, and they use very literal, straightforward terms. One of the patients came to the clinic once and asked me, Doctor, when women get into certain age, we call this menopause. He actually pronounced it in that way, menopause, not menopause. So I think it is wrong, doctor. We should refer to this as woman pause, not menopause. Although he was he was very fixated on that. He didn't say that in a jokey manner, or he was very fixated on this term. They have significant problems in social interactions. And when you do that assessment, you ask them how do they behave in social gathering, what do they do there. We talk later about masking and exhaustion. Also, when they talk to other people, do they take turns? Sometimes they tend to just talk and talk. They don't hold a two-ways conversation. The conversation is just one-sided. Although you can see this in different areas that people tend to just talk and don't listen, but it is very peculiar in people with autistic spectrum disorders. And they may not be aware of what you need to know or what you need to hear. Making small talks. Can anyone tell me what do they and what do you understand from small talks? What do we mean by small talks?
اوكي. يعني الكلام بيكون مختصر، ما
Mhm.
يعني لما تيجي تسأل تقول له هاو ار يو، بقول لك فاين، ما بقول لك I'm fine thank you how about you كده يعني. ردودهم
Mhm.
بتكون مختصرة.
اوكي. انت قريب من الاجابه، لكن small talks.
In a
This
concrete
is
way, doctor, that means they will not speak in abstract, elaborative way. They will speak in a concrete methods.
no, actually, small talks is probably because it is something which is maybe peculiar to the culture in UK. They have this. They refer to small talks when you meet an English person in a train, for example, in a meeting, and if they don't know you, they will not actually initiate conversation in details. They will start by saying, "Oh, the weather is nice. Oh, are you busy today?" Oh, so these are the small talks, talking about these things like the weather, what's happening. I mean, instead of talking about the actual issue that people are there to talk about. And this is actually like a very recognized way of communication in the culture in the UK. People usually start about the weather. I don't know why the weather, but usually they say, "Oh, the weather is nice today. I hope it will be nice in the weekend. Oh, it is not raining today. Oh, it's horrible today." So that's one of an example of small talks. I remember assessing a patient with autistic spectrum disorder, and when I asked him about small talks, and he told me, "Oh, I hate small talks." So somebody says to you, "The weather is nice. So what? So what? What does that mean?" So they don't like small talks. This is one of the things that you find maybe in most patients with autistic spectrum disorder. Also, when they talk and they say things, these things might offend other people, but they are unable to recognize that. They have a huge problem in building and maintaining relationships. So usually the relationships, they end up in a very drastic way, and they don't maintain the relationship for long because of all these differences. They also they are very they have reduced interest in socializing because of these difficulties, because of their difficulties in interaction with other people, difficulties in communication, difficulties in nonverbal communication. Because of that, because sometimes they are aware that they might say something inappropriate when they socialize with other people. So that's why they tend to avoid all this social gathering altogether. We talked about masking. Some patients, some individuals with autistic spectrum disorder, they have this ability to mask their issues, their problems, their difficulties with communications. It has this term that camouflaging. I think we need just to Google this where that come from. But if you read about autism, you'll find this term frequently mentioned. And this can come either consciously or subconsciously. You may find them able to present and talk in a way that is different from people with autism, but this is actually a skill that they develop in interacting with other people. It is more common in women for some reason. We go back to the core symptoms of autism, and one of the symptoms you might hear about this, or you might see it written very often, lack of empathy. And to me personally, this is debatable. I think we all know what we mean by empathy. Seeing things from others' perspective is different from sympathy. I think some people with autistic spectrum disorder come across as very egocentric, just focusing on themselves. They don't see things from others' perspective. They don't actually recognize if somebody else is suffering or somebody else is sad or somebody else is not well. That's been mentioned in the problem with reciprocal social interaction, but I think it's still debatable. I personally have seen many individuals with autistic spectrum disorder with empathy. They think about others. Yes, we're coming to theory of mind. Yes, that's right. So I've seen, as I mentioned, I have seen some individuals with autistic spectrum disorder with very good sense of how other people feel, to the extent that makes them very sad sometimes when they ask the questions to somebody who is very close to them. Am I making you sad? Are you sad? Are you not feeling well? So I haven't gone through research to see how often the lack of empathy is there in individuals with autism, but I have come across some individuals who have empathy and who have even empathy more than neurotypical people. And I think one of the theories about empathy, which explains this, that we have a double empathy theory. And that the double empathy theory says that the mutual misunderstanding that often occur between people with autism and others, and people with autism may struggle to interpret others' social norms, while others often fail to understand people with autism. Because the question will be raised, who decides that this should be the norm? Who decides this should be the social norm? And how do you decide that this individual has not been able to understand or to have empathy towards other people? How do you decide that? It might be you are unable to understand their difficulties. You, as a neurotypical, are unable to. You are unable to look into how difficult for them is to communicate, how difficult for them is to understand all these complex emotional and psychological and social issues. So we always need to not to be biased here and not to just to say that all and to generalize to say all people with autism, they lack empathy. We need to look into our understanding of them as well. We talked about now. One of the very important features of autism is having restricted repetitive behavior. And this includes not only the interest or activities, but also it could include also the pattern of thinking, the pattern of dealing with changes, coping with changes. People with autism, autistic spectrum disorder, they find it very difficult to deal or cope with any change. Our patients, they have routine that they go through. Once that routine is changed, they find that very difficult. And I think nowadays, I think our patients with autism in Sudan, they are suffering because of the war and the changes that happened because of the war. Moving from one area to another, having to go through all these changes, that's actually causing them a lot of distress. Because even minor changes from working with patients with autism, that can trigger a meltdown, can trigger aggressive behavior, can trigger a depressive episode, any changes in routine. is very difficult to deal with. So they like to have this routine and to have everything to be predictable for them. Sometimes if you tell a person with autism that, okay, if he's waiting for you, okay, I will see you after 5 minutes, it has to be 5 minutes. Sometimes we just say this, oh, 5 minutes, but if you make that beyond 5 minutes, that can actually trigger agitation, can trigger an anxiety. They have difficulty in multitasking, and I must confess, most men have this difficulty. Maybe if we have female trainees, female doctors with us here, they can confirm that most men, they have difficulty with multitasking. They will be very passive if, I think there's a mistake. Okay. Yeah, I can see that one of our colleagues here is actually confirming, or she's liking this, that most men, they can't multitask. But I don't know what Azama and Abdulghani will say about that. Now, patients with autism, they have special interest in certain things, certain hobbies, and they have very deep interest in this. When you talk to them, and if you are not talking about their interest, they will become very passive. They will not engage. I remember assessing a woman in her 50s for autistic spectrum disorder. She came to the clinic, and for the first hour, she did not engage at all. And her answers were very short. She didn't appear to understand any of the questions, to the extent that I was thinking, oh, this patient must have intellectual disability. And then we came to the area of this special interest, and I asked her about her special interest. And then she told me that her special interest is in Twitter. At that time, before they changed the name into X Factor. So she told me, oh, I'm interested in writing in Twitter. And then I got interested also. I asked her, what do you write about? Oh, I write about politics. So I thought of, oh, this is a good area to get her engaged. So I asked her, so tell me, what do you think of Brexit? Brexit at that time when the Great Britain decided to come off the European Union. What do you think about that? What do you think about Brexit? And then from that point, this woman changed from a patient who was not engaging, a person who was very passive, a patient whom I thought she had intellectual disability, into a politician. I thought I was just watching BBC, listening to a politician talking about Brexit, and she gave me a lecture on that. So when you assess patients with autism, when they don't engage, try to find the area of interest and try to engage them from that area. So we talked about tendency to sameness, wearing the same clothes, and thank you, eating the same food. I've come across patients eating like fish and chips every day, eating chicken nugget every day, and not changing that at all. If they are offered any other food, they won't change. You see that some patients with the same clothes every day is not an issue of that they have poor self-care. It's just the tendency to wear the same clothes. In addition to this, there might be some sensory processing difficulties that includes smell, taste. I've seen patients smelling food before eating it, and some patients they get very disturbed with loud noise, with lights. Some patients, on the other hand, they sleep only if the light is on. Some people with autism they get very comfortable when they touch certain textures. So they have in some care home they have a sensory room for them that helps them to settle down. Also, the sensory processing difficulties can include also like lack sensation of fullness when they eat. They just eat and they don't have that sensation that they are full. Sometimes they have very high threshold for pain that might lead to some injuries when they don't feel the pain. So now we will move to diagnosis of autism. But before moving to that, are there any questions? I think because if we talk about diagnosis, then we might get into a different part of the presentation. Any questions before that? Okay. Just before we move, I just remember one of the fixations on things. When you see individuals with autistic spectrum disorder, sometimes they have very strange fixation. I remember seeing a patient with autistic spectrum disorder. His main fixation is on like some PlayStation games and watching some movies. But his fixation is quite strange. He doesn't like the dominant figure on movies and on PlayStation games. He will find the non-dominant figure and will try to follow them and find anything related to them. Sometimes he goes to some of the shops to find the T-shirt for the non-dominant figure. And that was actually causing him a lot of distress. When I saw him, he told me that the world is full of dominant people and they have the upper hand. And I find it very difficult to live in this planet. So, and when he mentioned this to his mother, she became concerned that when he said he doesn't want to be in this planet, that means that he's suicidal. But when we explored that, I just found out that he was fed up with the planet that's full of dominant people, that they are actually dominating everything in life, and other people who are non-dominant, they just have to follow them. And he was find that very difficult to get out of that fixation. So this is one of the very strange fixation that you might find in individuals with autistic spectrum disorder. How are we doing with time? Yasir,
كويسين.
are we okay with time?
Yes.
Okay. How much do I have?
For the hour, I think 10-15 minutes, but I think the topic is interesting, so keep going on.
Okay. النقطة الأخيرة.
القصة حقت الشاب ده أنا ما فهمتها.
الشاب. الشاب هو يعني مهتم ببعض الأفلام وبعض الأشياء اللي بتكون في البلاي ستيشن جيمز. في الأفلام دي البطل والشخص اللي بيكون دومينانت معظم الناس بيكونوا متعاطفين مع الزول الدومينانت، مش كده؟ مع البطل. هو بالعكس، هو بيفتش على الشخص اللي بيكون نون دومينانت وبيتعاطف معاه. لكن المسألة دي مسببة له يعني ضغط نفسي شديد، إنه هو شايف إنه كل الناس متعاطفين مع البطل، والبطل دائما هو اللي بيفوز، ودائما هو اللي بيكون يعني أموره ماشية وبيفرض حاجاته على الناس التانيين. هو شايف كده يعني from his own perspective, and it was causing him a lot of distress. And that's not a fixation on one day. It's a long-standing fixation. One of the movies that he's been watching and following, the stuff, they were trying to hide this from him. If the movie is coming on TV, they will not let him know. If the movie is coming in like a new version of that movie, if he knows about that, then that will cause him more stress. كده واضحة؟
ايوه واضحة كده.
شكرا. So I was telling this story because I think sometimes when you find somebody with autistic spectrum disorder that's suffering from all this stress and anxiety, as well as depressive symptoms, and this strange fixation, sometimes if you are not aware of the concept of autistic spectrum disorder and the core symptoms and the fixation patterns that they have, you might misdiagnose this as severe depression with psychosis. You might consider this as delusional disorder. You might start to consider prescribing antipsychotics for them. So we need to explore this in more details and in depth. The diagnosis is part of the assessment, and it involves thorough assessment, including the clinical interview, structured tools, and MDT approach. When I work with the autism team in Bedfordshire, we used to have initially the clinical interview. We used to apply the Royal College guides on that. And following that, in a separate session, the patient will be assessed by a different member of the MDT and using the tools, the likes of EDOS2. And then following that, we will have a meeting to discuss our findings, and then we write our reports, and then we agree in the meetings whether the two assessments conclude that this patient has autism spectrum disorder or not. And then once we agree on the diagnosis, then we confirm the diagnosis. So the diagnosis, before we start even the clinical interview, we have the initial consultation and screen for symptoms using some of the tools, the autism quotient. And the diagnostic interview, as I mentioned previously, you need to have a family member there to have objective observation of the patient and collateral history. And you can use also the assessment tools, as I mentioned. And then you apply the ICD-10 or DSM-5. Maybe Yasir will tell us about DSM-5, because we in the UK, we are very obsessed with ICD-11, and we use it rather than the DSM-5. And then once we confirm the diagnosis, we inform the patient of our confirmation, and that is part of the assessment. And then following that, we need to assess patient's needs, and then we need to signpost support and treatment for the patient. if they have any other comorbid conditions. Sometimes some of the associated conditions, I've just listed them. You might see them in patients with autistic spectrum disorder. One of the common conditions is the combination of ADHD and autistic spectrum disorder, and that's a difficult combination to treat because the symptoms impact on each others, and the patient become very complex. So these are the list of just some associated conditions. And mainly these neurodevelopmental conditions that mostly associated with autism and autistic spectrum disorder. I think that's a mistake. Number 3 is tuberous sclerosis. I think this, somebody was helping me with the PowerPoint, so they've written it in the wrong way. Apology for that. If you are interested, you may just list them and read about them more. Because if you are working in the area of intellectual disability, you may come across of these conditions. Now, before I go into the references, just and maybe from my own experience and advice to trainees or advice to any one who is interested in this field. This field is not only for us medics. You find a lot of people from other disciplines, including speech and language therapists, social care, nurses, psychologists. They all work in this field. I remember once I was attending a course in autistic spectrum disorder, and part of that course we needed to write assignment, and the university lecturers were very critical of some of the terms I used. So you need to be mindful of that. We, as medics, we use these terms like comorbidity, disability. We use them just sometimes subconsciously, but some people with autism and also some people from the social model who has some views about the medical model, they don't like using these terms like disability and comorbidity. So instead, you may say difficulties, you may say just associated conditions. For some reasons, they don't like the medical terms. So some of the references here I've written, I think there's a mistake here also. The first one is a book called Neurotribes. It's the legacy of autism and the future of neurodiversity by Steve Stelberman. I don't know whether has anyone come across this book. It's a huge book. It's a big book. It's not like an academic reference. It is a book which is actually written in different way from other academic books. But I would recommend anyone who has interest to find this book and read it. You may need a long time, 57 days to finish the whole book, but I think it is a very interesting book, and I found it very, very stimulating. And Steve Silberman is the writer who has views about how the society look at individuals with autism. He advocates for including individuals with autism in our society, and he has a lot of views, critical views on how people treat individuals with autism. He's also mentioned some stories, some success stories of individuals with autism. So I think I would recommend everyone to find this book and try to read it. There are other books from, I mean, these names you find whenever you search for autism, you find these names there. Simon Baron Cohen and Donna Williams. They are known figures in this field. So I think we may come to the end of the presentation. And any questions, please, Dr. Abdelghani and Dr. Yasir, no on the type questions, just questions. Thank you.
All questions are allowed. Freedom of questioning.
Thank you.
في الشات في a lot of questions يا
ده اديك اسئله قديمه. افتكر في سؤال في نص المحاضره كان was the delayed diagnosis due to parental neglect or was it misdiagnosis؟ دي افتكر على نقطه كان في الاول.
Okay, yes,
لكن
yeah, I remember seeing this question.
آخر سؤال طيب ممكن تعيد النقطة الأخيرة دي مكتوبة حسي
لا ده عمل
دي
جيبين برضه اتناقش
لا
فيه.
جاوبتها دي
مم.
جاوبتها. السؤال عن شكرا. السؤال عن misdiagnosis, is it because of neglect? No, I don't think so. No, I don't think so. I'm sure that parents most of the time they look after their children and they don't neglect them to the extent of not helping them to get the diagnosis. I think it's probably just the knowledge and education, and for that, I think one of our targets should be like education to parents to be able to recognize the differences in their children and to recognize the symptoms and ask for help. I hope I have answered the question.
عبد العظيم افتكر رافع يده في سؤال وبعده عامر.
شكرا يا ياسر. شكرا يا دكتور عماد. يا عماد والله is a very nice lecture. I like it a lot. Very
Thank you.
useful حقيقة.
Thank you.
أنا بس حقيقة عندي سؤال. يعني أنا الاكسبيرينس بتاعتي is very low actually في ال ASD ولا autism وكده. عن الاسبرجر سيندروم لأنه بيجي كتير في الادلت كلينكس وكده. What is the relationship between it and the autistic؟ يعني بتكون very good لو بدنا بس نعرف ال relationship briefly و how to assess it في الادلت الاسبرجر syndrome.
Okay, thank you very much, Dr. Abdelazim. I think now the ICD criteria, ICD-11 criteria, focuses mainly on autistic spectrum disorder. And when we say spectrum, we mean that it has a wide range of different presentations. In the past, Asperger's syndrome was only limited to individuals with high functioning autism, meaning that they have high intelligence and they have also high functioning, different to individuals who are struggling to function and individuals who have autism with intellectual disability. However, now they are limiting all the diagnoses in autistic spectrum disorder. So, but you can still find this diagnosis mentioned. The way you diagnose Asperger's syndrome is the same way. You go through the same structured clinical assessment in addition to the tools, and then confirm the diagnosis. In some conditions, if the presentation is very obvious and you can confirm the diagnosis only from clinical assessment. You don't have to go through the structured tools, but these are not common. So the Asperger's syndrome is one of the autistic spectrum disorder conditions, but it's not the term. I don't think it's used now, but in terms of like ICD-10, 11, and criteria, but it's still clinically still used. So it's part of the autistic spectrum disorder in general.
شكرا لك دكتور عامر.
Hello, doctors. Hello, everywhere. Thank you for the appreciate it. Thank you for this so interesting lecture. My question, I feel some difficulty to recognize that, as you said, that you have patients over 70s that will diagnosed with autism spectrum. Is it, so difficult that their parents and socially around, they didn't distinguish this the clinical features of patients of autism when he's young, when he's a child, to be an old man for over 70 years old. I feel that, some interventions with some personality disorders like she's liable, avoidant, how we can, distinguish or differentiate it between these disorders that I feel that's so difficult for me as registrar doctor. The second question is, do we have a scale to make 100% diagnosis of autism in adult? Thank you, sir.
Okay, thank you. It's a very good question. I think that patient who is in his 70s, I just I go back to the story. I think I've seen him in a care home, and his carer was just referring that's just him. There's nothing wrong with him. But I was able to recognize some of the symptoms of autism. Unfortunately, because of the circumstances, we were unable to pursue the assessment. I mean, but because he has been cared for, he's been interacting well with his carers. They've been looking after him for decades. The only problem happened when he went into general hospital, and that was a massive change of routine for him and change of staff. Staff were unable to interact with him in the same way his carers were familiar with his care. So they called us and they asked us to see him because they felt he was agitated. He might be suffering from depression. So because he had a physical health problem, we asked them that after treating the physical health problem, after discharge, we will see him in his environment. When I saw him in his environment, his carers were very happy with the way he was presenting, and they just confirmed that. I just remember they were saying that's just life. There's nothing wrong with him. So they are the conditions that you mentioned, like the some of the personality disorders. Yes, the schizotypical personality disorder, the psychopathy, and some of them they share some of the symptoms of autism. The lack of empathy, it can be shared between somebody with antisocial personality disorder and as well as somebody with autistic spectrum disorder. However, you may find that this person with antisocial personality disorder, that in addition to this lack of empathy, they have other characteristics which are not found in anyone with autistic spectrum disorder. The tendency for manipulation, the tendency for aggressive behavior, the crime records, a lot of symptoms that you don't find in patients with autistic spectrum disorder. Now you ask about scales on how to diagnose or to confirm the diagnosis. the structured tools, the like of EDOS2, they have a scale of logarithm is rather a bit complicated. There's some coding that you use, and then after the end of the structure assessment, then you add the codes together, and there are some rates. If the patient falls within these rates, this can confirm the diagnosis of autism. So the scales are found in this structured assessment. However, we do prefer to do the combination of clinical assessment in addition to structured assessment. I hope that answers your question.
Thank you. في أسئلة من الشات. Dr. Nader Mekki, thank you for the interesting topic. What about management and prognosis? سؤال كبير.
That's another lecture. This management and prognosis is part of the assessment process, because you will not complete the assessment unless you assess the needs, and then the assessment of needs that actually inform how you manage patients with autism. And I'm glad that you use the term management rather than treatment. The general advice we give to families and individuals with autistic spectrum disorder is that the core symptoms, there is no cure for them. There is no treatment, but the associated conditions and the conditions related to autistic spectrum disorder, like anxiety, symptoms similar to OCD, depression, psychotic episodes, all this, they can be treated in a way that meet the needs and also manage the risks. However, the treatment in general for any associated condition will be different from the way we treat the conditions without autistic spectrum disorder. So although it sounds negative that there is no actual treatment for the core symptoms, however, what I try to educate families, individuals, and also give them some positive perspective to say that these core symptoms, I don't see them all are as problems. The people with autistic spectrum disorder, they are not actually mentally ill. That's what I try to deliver this message. They are actually different from other people, but they have very good qualities. Personally, I think that they are good qualities for somebody who's honest, open, who's able to communicate things in a very direct way, who is very very naive in a way, that not understanding sarcasm or not unable to read between the lines. This is not actually a bad quality. It just tells you that this person is very direct and honest.
Thank you. في سؤال في الشات برضو هنا. Is it usual to see parents of an autistic child presenting with autistic features in the parents themselves?
Yes. This is a very good question. I think the very good observation that I've noticed in some parents with individuals with autistic spectrum disorder, they themselves, they come across as quite, I don't like using the terms autistic, but they have some of the core symptoms. But if you explore that, they don't come across as having the whole picture. But sometimes you do wonder if these parents were assessed, you might find that they have autistic spectrum disorder themselves. I remember one of the mothers of a patient with autistic spectrum disorder. She used to come to the meeting with a diary, writing every specific detail about the management, every treatment the patient had, very well organized. I did think that can be, if you explore that, it can be just some of the symptoms of autistic spectrum disorder, but it was beneficial and it was actually positive to us. Thank you.
Thank you. في سؤال من هناء هنا بتسأل عن الdiagnosis بتاع adult autism spectrum disorder. Does it require a childhood onset, even if the symptoms are met during adulthood?
Well, when you assess adults, before you start the clinical assessment, you need to go through the developmental history. And that usually will tell you that they were some symptoms during childhood and they were missed. Nobody will just all of a sudden, as an adult, become suffering from autistic spectrum disorder. It's just a misdiagnosis or misperceived. Some of the symptoms will be there. So that's very important that you need to take the developmental history from the start.
Thank you very much. أي معقبين، أي تعقيب؟
الو السلام عليكم.
وعليكم السلام
ورحمة الله وبركاته.
انا ما عندي حاجه، اقدر اسلم على عماد.
عليكم السلام، اهلا فتحيه، كيف حالك؟ ان شاء الله بخير.
كيفك؟ تمام
الحمد
أسامة.
لله الحمد لله.
الله يسلمك.
سعيدين بحضورك والله.
الله يسلمك، دخلت متاخره بس.
لا ما مشكله.
الله
ياسر ان شاء
يبارك.
الله يرسل لكم البرزنتيشن كله
بيرسل من لي ريكوردنج.
بعد ما
ياسر
يعمل له.
ازيك؟ كيفك؟
الحمد لله كويس والله. كيف أخبارك؟
والجميع كلكم ان شاء الله، ودكتور عبد العال
كل لون التالي يا سيد احمد. انا تالي يا سيد احمد.
إخوان في واحد
تالي يا
فاتح
سيد احمد.
اوكي، شكله في واحد فاتح الميوت. اي زول عنده تعقيب، اي زول عنده مشاركه؟
لو سمحت لي يا ياسر. شكرا عماد. Very nice lecture, no doubt. How frequent do you see adults with autistic spectrum disorder يعني الprevalence, and do they انت قلت في functioning طبعا في definitely impairment of social functioning، لكن what about their academic performance, work abilities and jobs? Do they get married when they are 50s or 60s in the cases you have seen? Thank you.
Okay. Thank you. It's a very good question. I think the prevalence in general it is 1 in 100. It can be different in some areas. I think in America they mentioned that it can be up to even one in every 36. But I think in general it's 1 in 100. The second part of the question is, from my experience, I have seen individuals with autistic spectrum disorder and intellectual disability. But the intellectual disability it was not a product of autistic spectrum disorder. It's just a combination. However, some individuals with autism have been very successful, and some of them they actually they managed to achieve academically. And maybe some of the core symptoms they used, they were beneficial to them in a way. They were fixated in certain areas, and that helps them to achieve academically. And even have some doctors with autistic spectrum disorder, but they've been very successful. So in terms of academic achievement, yes, most of the time they achieve very well. In terms of relationship, from the individuals I assessed, I mean, some of them they manage to have a successful social marital life. Some of them they still finding it difficult to get into any relationship. And I think one of the observation that sometimes it requires understanding, awareness of the condition to get into any relationship with somebody with autistic spectrum disorder. So I've noticed that the partners or the husbands, wives of individuals with autistic spectrum disorder, they have very good understanding of the condition itself. In other examples, people with autistic spectrum disorder, they have relationship with each others, and that's proved to be successful because I think they have understanding of their needs. That's their part of the questions. Have I answered or parts?
Sure.
Or
Sure. Thank you so much. Sure.
طيب انا رسلت السيرفي وفتحته، افتكر يوسف قال لي ما كان في، افتكر في requires request، لكن افتكر فتحته المفروض انه يكون اتحل. في سؤال انت اوريدي جاوبته، كان مخطوط في الاسئله هنا، جاوبته في كلامك الفات. إذا بيسأل do coping mechanism developed by adults with delayed diagnosis make their diagnosis more difficult، انت جاوبته بس قبل شويه في الهناية في النقاش. وفي سؤال عن ال confusion with the diagnosis between autism spectrum disorder in adults and dementia.
Dementia. Okay. Yeah, that's an interesting question. I think the presentation is different. It might be in some cases you find some overlapping in the symptoms, but the presentation is definitely different. And in dementia, you have to. It's mainly about the cognitive functioning and the impact on functioning, the memory problems, and you don't find those in individuals with autistic spectrum disorder, unless somebody who's in like late age and then presenting with cognitive impairment, but also they have traits of autism that might be just misdiagnosed from early age. I hope that answers the question.
أعتقد ده آخر سؤال عشان نقدر بعدين نمشي، اللي هي some symptoms causing an anxiety and distress to autistic patients, as you said, can we say it is ego dystonic?
Okay, that's a good question. I think maybe it's difficult to generalize to say that the whole condition is ego dystonic, because some individuals are able to manage well and they are able to overcome these triggers for anxiety and depression. But yes, in most of the cases, they are prone to anxiety and depression, and their awareness of their symptoms, I don't say it is ego dystonic. It does help them if they are aware of the symptoms and aware of the way that people perceive them. That helps them to overcome anxiety. But if they have difficulties in achieving this, or other people are not recognizing their needs. For example, if we are caring for somebody with autistic spectrum disorder and we don't follow the routine, we don't stick to the timing, we don't understand their needs, that can cause anxiety and depression. So the causes of anxiety and depression, they are not mostly from the condition itself. They can come from extrinsic factors rather than intrinsic factors. So anxiety and depression, we all contribute to that if we do not understand, we do not recognize the individual's needs.
Thank you very much. أنا أفتكر دي كل الأسئلة موجودة يا إخواننا. السيرفي رسلته الريسبونسز لحد هسه من حوالي كم 70 واحد almost 15 بس.
Yes,